Hello guys, welcome back to another video. Now many of you have been asking me about my college and how the facilities are over here in UP and whether or not to join the college, if there is patient exposure, if the fees is worth the money. And I would say that so far things have been okay in my college. So this is typically one meal that they offer in the college. We get three meals: breakfast, lunch and dinner. Sorry, four meals, also snacks. And other than that, about the OTs, we have to prepare them each morning. Every week, every alternate week, we have 24 hours duties, and twice in a month, we have ICU duties. So, our job every day is to go and prepare an OT, and based on which OT we prepared, we get to attend those surgeries. We are not pre-categorized into ortho, ENT, gynae or surgery OTs, but we just get them as and when we go to the OT. So this week was quite hectic at the OT because there were a lot of different cases, and I had to do a lot of studying in the background to keep myself updated with the procedures that are going on in the OT. So basically, every morning we just have to go and prepare the OT, as in check the machines, check the equipment, and load drugs for either GA or spinal. In case of general anesthesia, the drugs that we load are as follows: Butrum, diclofenac, dexamethasone, succinylcholine, midazolam, loxicard, vecuronium, propofol, and of course at the end we load reversal, and we also load vecuronium as non-depolarizing muscle relaxant. So once we are done loading the drugs, we check for all the equipments. We have to check for laryngoscope, we check if all tubes are present in different sizes, we check for suction catheters, we check for RT, we have to keep loose gloves ready, we check the machine for any leak, we refill the inhalational induction agent, which is isoflurane. We also keep the emergency drugs ready, namely atropine, meth, and glyco, and we load ondansetron for all patients, regardless of whether the case is in spinal or general anesthesia. Some other emergency drugs have to be kept ready in the OT. We don't always load them, but we always have them, like dobutamine, dopamine, nitroglycerine, esmolol, so that we can use them if there is any emergency during an OT. And at the time of extubation, we have to be careful that patient does not undergo laryngospasm. If that happens, then the patient needs to be re-intubated. So we have to keep drugs ready for re-intubation, and also patient has to be given muscle relaxant like succinylcholine to relieve the spasm, which we also keep ready. And yeah, so that's basically it for the OT. And at the time of induction, we have to first wheel in the patient, connect the vitals, check the vitals before starting induction, and then start the induction by giving an anxiolytic like midazolam, and then some painkillers like Butrum, diclofenac, then the induction agent propofol with loxicard to minimize pain, and then succinylcholine or the muscle relaxant, after which we look for fasciculations. When the fasciculations disappear, we do the head tilt chin lift maneuver and then hold the mask in C and E technique so that there is no leak, and pre-oxygenate the patient for 3 minutes, after which we do laryngoscopy, visualize the vocal cords. Vocal cords are the only white structures that you will be seeing in your field of view once you do the laryngoscopy. So the two inverted V-shape white structures are the vocal cords, and you have to place the tube in a way that it slides in between those two white vocal cords. And then you have to check for placement, correct placement. You have to check at the epigastrium to rule out esophageal intubation, and then at the axillary, mid axillary line to check for bilateral equal air entry. And then finally you can connect the patient to connect the circuit to the ventilator and start the inhalational induction agent, which in our case is usually isoflurane. And you have to set the tidal volume, which is 6 ml per kg as per the patient's weight. You have to set the frequency, you have to set the PEEP, and then you have to set oxygen and nitrous oxide in the ratio of 2:3. Nitrous oxide causes second gas effect and also produces analgesia. And at the time of reversal, first of all we switch off the nitrous oxide, and then we switch off the inhalational induction agent, and then once the surgery is complete we give reversal slowly. And finally, when the patient's tidal volume for spontaneous breathing is sufficient, then we bring the patient to wakefulness by arousing the patient and then extubate the patient. So this is the training that we have been receiving for the past 6 months, and we are learning slowly day by day. This particular day I was preparing the gynae OT for a transabdominal hysterectomy, and you know that this is the gynae OT because you can see the pediatric incubator lying at the diagonal end of this room. And it was quite an interesting process. In case of spinal anesthesia, the 4 initial drugs remain the same, which is atropine, glycomef and Onden, and then we use a spinal anesthetic, which is bupivacaine 0.5% heavy, and sometimes we use an additive, but not in the case of emergency LSCS. So additives can be like dexmedetomidine or clonidine. They are meant to prolong the action of the local anesthetic and prolong duration of analgesia in patients receiving subarachnoid block. So this is the final product. It's very satisfying to watch all your injections in place and machine checked. I love OT lights. I'm obsessed with OT lights, and this is what we basically do every day repeatedly. It gets a little monotonous at times and it can get quite boring if you're sitting
When
in
the
the
OT
OT
is
just
nearing
looking
an
at the
end, in
screen
case of
and
general
monitoring
anesthesia,
vitals.
we have to prepare the
But
reversal, for which we use
emergency
5
can
ml
happen
of
anytime,
neostigmine
and you are
and
just there so that
2
when
ml
it
of
happens,
glycopyrrolate
you
to
take control of the situation and
compensate
save
for
the
the
day.
side effects that neostigmine might cause.
That's our
And
principal role as an
at the time of
anesthetist,
extubation, we have to take care
to
that the patient does
never
not
let
undergo
situation get out of
laryngospasm.
control,
In that case, we have to
and
keep
to
muscle relaxant
tackle
ready
any emergency situation quickly.
to prevent
So
spasm.
after a long day at the
After a
OT, I
long
do
day
some
at the OT,
skincare
I
and then
like
I
to do
spend
a
time
little bit of
studying,
skincare,
but
and
not every
I
day,
like to
I
spend
have to
my
be
time
honest.
studying.
So this is my
So
day in a
this was my
nutshell.
day
I
in a
hope you
nutshell.
liked it.
Hope you liked it.